Dr. Beilan. I appreciate everyone for being here on our AUI Men's Health webinar. Tonight, we're going to be discussing men's sexual wellness and why it's important to talk about it and steps to take to improve it, and some broad overview of various important topics within men's health, which is a subject I'm very passionate about. So I appreciate you being here online with me this evening. If there are any questions that come up during the webinar, feel free to type them. They'll get kicked over and I'll try to answer them as we go. And if I'm on a roll and I miss it, I'll try to circle back at the end and make sure we have everything answered. So we have about a half a dozen different topics that we'll go through. But first, let me tell you a little bit about myself. So I was actually born and raised here on the Gulf Coast of Florida in the Tampa region. Went to the undergraduate studies at UCF in Orlando, stayed there for medical school, came back to Tampa for residency training. That was 2013 to 2018. And did specialty fellowship training out at the Beilan College of Medicine in Houston, where I focused on male reproductive urology. And there's where I gained additional knowledge to learn about men's sexual health, male fertility, erectile dysfunction, Peyronie's disease, all of these topics that I'm lucky enough to build a career at here in the Clearwater Largo area. So we have practices at my AUI office in the Largo region, as well as Palm Harbor. Although Advanced Urology Institute, as we may or may not know, is the largest private practice urology group in all of Florida, and we have offices throughout the state. So if you can't make it over to the west coast of Florida, I'm sure there's an expert near you. So let's dive into it. Why are we discussing sexual wellness? Well, managing a patient's sexual health really touches on all aspects of their care, ranging from the physical to the mental, to the relationship interplay that goes on with their partner, and the long-term health is affected for both men and women alike. And one important topic, this slide's interesting, it contrasts how women are more knowledgeable about sexual health, more likely to talk about it, and more likely to seek aid than men. And so this really represents an underserved population. Generally, we as men are more closed shut. If things are not going right, we're less likely to open up to our fellow men in the locker room or anywhere in society, for example. So this is something that men generally keep to themselves and don't seek care, although we do have solutions to a number of problems. This is an interesting study as well. 44% of men are worried about erectile dysfunction. I actually have seen studies that say that about half of men over the age of 40 have suffered some degree of erectile dysfunction. Know that about 1 in 5 men aged 20 and older do suffer from ED. And really the statistics speak for themselves in the number of men who have had or do have concerns about their sexual health, and maybe they don't, go seek help from a sexual health expert. So people like myself are in the community. We do enjoy talking about this. What I often experience are patients that come to me after they've been blown off by another provider, whether that's a primary care provider or their cardiologist who doesn't want to talk about their sexual well-being. Come seek a urologist, and specifically one who cares about sexual health and men's health in general. Okay, so our first of about 6 topics or so. And really, each of these topics could be their own lecture in and of itself, but we're just doing 2 or 3 slides, some general knowledge, and I want to use that as a springboard for discussion. The first topic being low testosterone. So this is when a man's body produces suboptimal levels of testosterone, and controversial, but depending who you ask, usually I go by the AUA guidelines of 300 nanograms per deciliter. And anything over than that is usually in the green. However, it is age dependent and population dependent. So, I'm not one to say that 301 is completely normal, whereas 299 is completely abnormal. I view it more as a spectrum. You have to take into account the patient's age, his comorbidities, his symptoms, and those symptoms are numerous. So signs and symptoms of low testosterone, the number one thing I hear about is low energy. Low energy, fatigue, doc, I can't make it through the day. I just have to have that 2 o'clock nap or else I'm going to be suffering. And that's despite getting 8 hours of sleep. I hear about low libido, low sex drive, obviously erectile dysfunction, loss of hair, hot flashes, moodiness, brain fog, you name it. And testosterone likely affects it within the male body. So it affects both the physical and the mental. And when we normalize the testosterone, boy, patients are so grateful and feel so much better. It's not just for sexual health. Replacing your testosterone can also aid in your cardiovascular health, your diabetic control for my diabetic men. Obviously, their psychosocial and psychiatric health. And most importantly, testosterone is a controlled substance. So this needs to be cared for by a provider who's familiar with testosterone replacement therapies, the various treatment options, and the side effects that can be occurred for someone on testosterone. Generally speaking, at minimum, I like to manage my guys by checking labs twice a year. And, I have a couple APPs who are well-versed in testosterone replacement that we kind of exchange patients back and forth, monitoring the labs, making sure that they're doing well on their protocols and making sure they're doing it safely. So different types of testosterone replacement exist, ranging from topical gels and ointments to oral medications, which are a little bit newer. You can take pills twice a day, nasal sprays, patches, pellets, and most commonly injections, whether subcutaneous or intramuscular. All right, next topic, Peyronie's disease. Now, speaking of underserved topics, this is probably maybe the top one of a men's sexual well-being. So Peyronie's disease refers to penile curvature, indentation, or really any change in morphology that happens with an erection. And this is from an inappropriate cascade of fibrosis that changes the collagen fibers within the penis, within a specific layer called the tunica albuginea. As these collagen fibers fibrose and become inelastic, you can get indentation or bottlenecking. You can get hourglass deformity, or most commonly penile curvature, because it contracts the penis towards that plaque, towards that piece of scar tissue. It is more commonly age 40 and up, and it's really untreated because of just a lack of awareness and understanding that this is not quite normal. There are television advertisements now coming out talking about the curved carrot, the bent vegetable, things like that. So that is starting to increase awareness, which I applaud. But it's important for patients to know that penile curvature, if it doesn't bother you or bother your sexual partner, is probably fine. But a lot of men suffer in silence, and they'll have a curve so bad that he can't even have penetrative sex. And that needs to be addressed, or else you're never going to get your sexual function back. Pain with the penis, feeling like there's a plaque or a piece of bone or a BB or something like something firm in the penis, which shouldn't be there. And also commonly associated with erectile dysfunction. So treatment options, we do endorse traction devices, most commonly RestoreX device. There are some good studies using that device. Oral medications, unfortunately, will not reverse your curvature or your plaque, but we do have injectable medications, which are very commonly used. That's a brand called Xiaflex, which we give in a series of injections to try to dissolve this plaque and eventually straighten the penis with appropriate counter-traction forces called modeling. And surgeries, which I do pretty commonly. We have penile plications, plaque incisions or excisions, as well as the penile implant, which can address both erectile dysfunction and penile curvature. So when I see a patient, it's important to get an understanding of what the physical exam is like. Is there fibrosis? Is there plaque? Is there pain? Are they in the active phase or stable phase of Peyronie's? And then we talk about treatment options, both surgical and non-surgical, to find something that's going to get him back in the game and bring back his sexual function. Okay, premature ejaculation. This can be a very difficult topic, not only to talk about, but to also treat. So one of the more common forms of sexual dysfunction, and it's a subjective answer, but a lot of studies use a minute cutoff of what's called intravaginal latency time. How long does it take once you begin penetrative sex? How long does it take to reach climax or reach ejaculation? And the old studies use this intravaginal latency time, although that doesn't really apply to my homosexual population. So it's not really fair to use these studies, but we still use a minute cutoff in general. That doesn't mean that if you have a minute and 30 seconds that you don't qualify for a diagnosis. This really does go by the degree of bother from the patient and his partner. Really an emotional distressor within relationships, and can cause a significant amount of strain, anxiety and guilt, and not feeling like you're manly enough to do the job that you should be doing, like you can't satisfy your partner, as with all of these sexual dysfunction pathologies. So treatment options for premature ejaculation range. Behavioral changes, which is typically where we start. We talk about relaxation techniques. How do you more slowly approach the point of inevitability? Counseling or behavioral therapy. We obviously want to look at the patient's medications, and certain antidepressant drugs may be effective. So the SSRIs or SNRIs are actually commonly used in this scenario to help delay the point of inevitability. Topical therapies as well. That's maybe the number one, most common thing that I use. Something like promescent spray is a topical anesthetic agent that can be used to decrease a bit of sensation and increase the time to orgasm and ejaculation. I just had a quick question come back on my last topic. How do you confirm Peyronie's disease? So Peyronie's is a diagnosis of pain, curvature, and plaque. And if you have one of the above, you may have Peyronie's disease. This is typically confirmed with a physical exam, and that's usually sufficient if somebody knows what they're looking for in an exam. And more commonly, I do use penile Doppler ultrasound in the clinic, where we will inject the penis with a pharmaceutical agent called Trimix. We're trying to induce an erection here. And then the ultrasonographer will look for plaque and look for fibrosis, look for curvature. It allows me to examine the patient while he's erect and curved, and we get a good sense of what's going on there. So again, a diagnosis of physical exam, although sometimes we do use ultrasound or even MRI. For example, if someone's had a history of penile trauma, we use an MRI to confirm what the structure of their corpus is doing. Excuse me. So once we have confirmed that diagnosis, then we can start talking about those treatment options that we went through. All right, vasectomy. Oh, we had a slew of vasectomy consultations today. I was running the vasectomy consultation clinic. It was great. So this is the #1 best option if a man and a couple is dead set on permanent sterility. That's really the main thing I'd like to harp on. I want this to be a lifelong decision, a permanent decision. We generally perform this under local anesthesia. We do bilateral spermatic cord blocks with a lidocaine type of agent. Usually takes me 10-15 minutes once I get started. We're basically putting a roadblock in the vas deferens, and it should not affect the patient's testosterone level, his sexual function, his erections, his ejaculation. We know that only about 2% of the ejaculate comes from the testicles themselves. The vast majority of ejaculate comes from the prostate and the seminal vesicles. And so just by putting a roadblock here in the vas deferens that you can see should not affect the actual fluid that comes out, although there will be no swimmers, there will be no sperm in that fluid. So after a vasectomy, #1 thing is to wear tight-fitting underwear. Keep the scrotum and the testicles well supported. Ice, Tylenol. We don't even write for pain meds. The patients don't need it. I ask for a week of downtime in terms of physical activity and sexual activity and exercise. And then generally at the 2 to 3 month mark, usually about 3 months, we get a semen analysis to confirm that there's 0 sperm. Oh, here's some myths. I skipped ahead. So here's a good one. It does not prevent STDs. That's very true. Reversals are sometimes possible, although not a guarantee. Oftentimes depends on how long it has been since the vasectomy itself. And it won't visibly change your ejaculate or the seminal fluid itself. Now, some patients are very nervous to undergo a procedure in the office with just a numbing injection. So we do offer laughing gas. I will take a patient to the operating room or the ambulatory surgery center to do it under like an IV sedation type of situation. It's such a quick procedure. Very rarely does the patient need an endotracheal tube or full general anesthesia. But the bottom line is we're going to keep you comfortable. We're going to get you through it, and we'll make sure that you have a smooth recovery afterwards. All right, male infertility. This is a large part of my practice and such a broad topic. You could spend hours lecturing. There are whole conferences on the topic of male infertility. But it's important to recognize that about 30 to 50% of couples are affected by male-related infertility problems. So almost half of all couples that cannot have a child within a calendar year have a male factor involved. 1 to 2% of couples are actually sterile, and that's important to recognize as well. There are genetic problems that we simply don't have an answer for in today's current science. So when someone's ejaculating true 0 sperm, there is a battery of genetic tests that we like to check. And it is also important that there are cures for many different aspects of male fertility. When I see a new couple for male fertility, I really try to do a deep dive, not only into his background, but also hers, to make sure that the female has received her appropriate workup. But from the male side, to try to look at them, zoom out, look at the patient as a whole. What's his comorbidities? How healthy is he? What other medications is he on? What other medical problems is he trying to deal with? Does he smoke or use, recreational drugs, marijuana or something like this? We ask about hot tubs and saunas and environmental risks. So, and then, we'll get all the history and also collect some data. Most importantly would be a semen analysis, as well as a hormone profile to look at their testosterone and their FSH and LH. These are gonadotropics. These are labs that are directly related to the reproductive system in a male. Sometimes we do ultrasound imaging, and oftentimes we do genetics in the most severe cases. So this is something that really does involve multiple clinic visits, but there is someone who can walk you through that workup as a couple. And trying to meet the fertility goals as a couple is the most important aspect. I did kind of skip ahead to this slide, but let's see if I skipped any of it. Yes, varicocele is one of the most common physical causes of male infertility. We estimate that about 1 in 3 men with impaired semen parameters have a physical varicocele. And a varicocele, I always tell patients, think of dilated veins in an elderly woman's legs, the varicose veins you might see in their lower extremity. The varicocele is dilated veins within the venous complex of the spermatic cord. And one of the theories is that as these veins are carrying slow and sluggish blood flow, it's regurgitative blood flow, these valves within the veins have failed and the blood flow is not unilateral. This slow and sluggish blood flow can overheat the nearby artery. And now you're delivering overheated blood to the testicle, and it's a subpar environment for sperm production. And so we can do microsurgery on varicoceles. We can do interventional radiology embolization for varicoceles. And it is theoretically a reversible cause of male infertility that I very frequently operate on. So you need to have someone who can diagnose it on physical exam. Occasionally we do get ultrasounds to confirm or rule out the diagnosis, and look for other causes of infertility, of course. Let's see here. We just had a question about ejaculatory function, a little bit of a side, but we're going to skip there because I'm reading it now. I just had treatment for an enlarged prostate and it can no longer ejaculate. Are there treatment options? This is actually something we deal with very commonly, and it is a difficult problem. So an enlarged prostate most likely will affect the urination in a negative way. And so I commonly do these procedures as well. You can do things like a TURP, a transurethral resection of the bladder, of a prostate. You can do a HOLEP, a green light laser, a urolift, an aquablation, a prostate artery embolization. There's a dozen different prostate-related procedures you can do for benign enlargement of the prostate, and many of them do risk function to the ejaculation. So let's say a TURP, for example, I quote an 80+% of it negatively affecting the ejaculate. And it's difficult because the resection itself and the procedure itself affects the ejaculatory ducts, where the seminal fluid deposits in the urethra, as well as the prostate itself, and you're resecting the prostate gland. Very difficult to reverse, unfortunately. One of the things we can try are medications for retrograde ejaculation, although that's kind of a different problem, and retrograde ejaculation de novo in a young, healthy patient is different than from a post-TURP or post-bladder outlet obstructive patient. But you can try medications for that. In short, there's not a silver bullet for a post-prostate procedure ejaculatory dysfunction, but you also have to make sure that that is the actual cause of the ejaculatory dysfunction. Is there concurrent erectile dysfunction or premature ejaculation you need to address? What was the function like before the procedure or surgery? So all of that goes into it. I would do a full workup and try to work with the patient in this and that. This is one of the things that we kind of try one thing, and if it doesn't work, we try the next, and almost an experiment as we work together through that problem. All right, let's move on. Erectile dysfunction, I believe this is our last topic, but it is our longest topic. So keep the questions coming. I obviously don't mind skipping around. This one does have a few more slides on it. So let's spend some time here on ED. Mentioned this before, about 1 in 5 American men have had experienced some form of ED at 20 years or more, at 20 years of age or more. And about half the men over the age of 50 have ED. So this is something that affects almost everyone. If you get enough guys in a room, you can look around and guess who has ED, and whether or not they are physically affected by it or mentally affected by it is another question, but obviously a difficult topic to broach. So this is just a broad overview of the erectile response itself. Really when I think about the erection, I think about blood flow in and out, and I think about nerves. Those are the two key important things to get a good erectile response. So basically what happens is physical stimulation starts a neuronal cascade, and you're aroused, and the smooth muscles of the corpora cavernosum relax, the arterial blood increases, the arteries vasodilate, and the veins are compressed. So the venous complexes of the penis are compressed against the sidewall, thus closing off outflow. And now you've created a state where you have inflow to the penis, but very little outflow, and you create a pressurized penis. And hopefully you can maintain that pressure through the act of sex. Very common causes are, diet, exercise, body habitus, weight, obesity, etc. We have cardiovascular disease and diabetes as probably number 2, number 3. a prior history of smoking, or even a prior history of poorly controlled diabetes for a year or two is very incriminating towards the sexual dysfunction. When I think about, ED patients, I often am wondering what their testosterone levels are doing, because that's just one piece of the pie. Think about your sexual function as a whole pie. You need multiple working pieces to create the whole picture. And certainly the patient's health and overall, comorbidities is there. You have to look at his medications, look at his, drug smoking history, look at, does he have a history of surgery, radiation, something to the prostate that's incriminating towards erections, and then look at the hormones as well. So I'm very commonly screening for diabetes or screening for low testosterone in my ED population. We know that diabetic patients don't respond as well to pills. So things like Cialis, Viagra, which is tadalafil and sildenafil, they don't work as well in the diabetic population. And it really doesn't matter what age you are. If you are 42 years old and you've been a lifelong type 1 diabetic, it's very likely that despite you being younger side, early 40s, that those pills just aren't going to cut it when it comes to getting your sexual function back. So this is something that I would treat more aggressively in the diabetic population. Also want to make sure that they're doing everything in their power to get their diet, exercise, weight under control, making sure we're monitoring that blood glucose, bringing down the hemoglobin A1C, because that will speak volumes with their sexual function. Cardiovascular disease is something else that I talk to guys about, every day. We often think that ED can be an indicator for heart disease. So if someone has ED, it precedes coronary artery disease and heart attack in about 70% of cases. So symptoms of heart disease often develop within 2 to 3 years of ED. So if I'm seeing a patient with ED, in the back of my mind, I'm ready to ask them about, do they have a primary care physician? Do they have a cardiology team? Have they been screened appropriately? And part of this comes from this slide. This is something I actually give in other patient webinars. I love this slide. The artery size of the first circle that you see is the penile artery. And it's about 1 to 2 times smaller than the main coronary vessel supplying your heart. So you can imagine that as these arteries block and occlude, and as cholesterol and plaque builds up within the arteries and the patient becomes less healthy, that the smallest one on the left is going to fail first, and the blood flow will be most restricted to their penile artery and their erections, and you'll get erectile dysfunction before the patient develops chest pain and heart attack, and before obviously you get the stroke and the internal carotid arteries of the neck and so forth. So this is just showing that if someone has had a heart attack, if someone has had significant coronary artery disease or cardiovascular disease, it's very likely that their erections are also suffering, and they need to see someone for that as well. Okay, let's take a pause. I did see another question come out. Let me give 1 second to read it. All right, someone's asking about the diagnosis of Peyronie's disease. So let's get back there. And how do we diagnose it? I mentioned the penile Doppler ultrasound and how we often give an injection to the penis, and that can be daunting. So the purpose of the injection is to try to induce a pharmaceutical erection, an artificial erection, where they'll get an erection. You can then do the blood flow measurements with the ultrasound, and that can see the patient erect and do a hands-on exam, etc. Oftentimes, it's not mandatory to do that. In a reliable patient that I can get a decent exam on flaccid, I will say, hey, and I did this today because our ultrasound bookings are actually booking out too far. And I said, if you can take multiple photos of a good, strong erection, multiple angles, top down, sideways, it's awkward to have a photo shoot of your erection. Not a lot of men do that on the regular. But bring me multiple photos. We'll swipe through them. We can delete them at the end of the appointment. But I just need to see from, various angles, what does the curvature look like? What pathology am I dealing with here? How can I mentally, help solve this problem? And I need to see the problem in order to have that discussion. So if we can get quality photos and just a cell phone, it doesn't have to be a Nikon 900 or whatever, but just cell phone pictures, multiple angles of a good strong erection, that can often suffice or replace the use of this injection and penile ultrasound. All right, we have one more question. Is there a test for microplaques for erectile dysfunction? And does AOI offer shockwave? And is it effective? Is it covered by insurance? Oh boy. All right. Let me take another water. We got 3 different topics here. So microplaques for ED is a hot topic where we're using micro ultrasounds. We do standard color Doppler ultrasounds, which will show you an excellent penile velocity through the penile artery, where we measure the peak systolic velocity and end diastolic velocity of the penile pudendal artery. And so that we can also look for plaques. That's an excellent study in terms of vascular response. And I oftentimes do perform penile duplex testing on patients who are failing pills. So that's kind of my mental, indication. If they're coming in saying, "Doc, I'm taking a Viagra, it's not really cutting it. What else can I do?" I say, let's back up and do this ultrasound test. Let me get a baseline understanding of your penile vascular function, and then let's have a discussion based off your results, get an understanding what's going on, and head in a direction that I think will work, and one that you want to go in as well. Do we offer shockwave therapy? Yes, although I do put a big asterisk by this one. So there are multiple different topics out there, different treatments out there for erectile dysfunction, which are labeled experimental or investigational by the Sexual Medicine Society of North America or the American Urologic Association, and this is one of them. And per their guidelines, really shouldn't be offering this outside of a clinical trial, and we do offer it, and there's a reason for that. This is me being in the Tampa market. It is so common to see patients who have had shockwave treatment elsewhere, from their chiropractor's office, from a men's health clinic. I've heard of it being offered out of men's salons, meaning like a hair salon. Regardless, I do believe that this shockwave treatment should be monitored by a urologist, and more specifically, a sexual medicine expert. I'm a believer in the shockwave treatment. That there is good data behind it, although early data, and I'm a believer in use for men with mild to moderate ED. I am not a believer in men with severe ED, men who have had deep pelvic surgeries or their prostate removed, men who have had radiation, someone who has had a lifelong 30-year history of diabetes and they're using injection therapies and it's not working. This type of patient is unlikely to significantly respond to shockwave therapy. And I try to be transparent about that because, frankly, we're charging cash for an experimental treatment option that may or may not work, and there's no guaranteed results. So I try to put that asterisk out there and have that blunt discussion with the patient. I do like shockwave for two reasons. Number one, there's very little clinical risk. You're not going to make the patient worse. You're not going to hurt the patient. Maybe some mild discomfort at the time of the procedure, but very rarely do I have a patient significantly complain about that. Usually they say, why couldn't we do more energy, more throughout the treatment? And if it helps, you have now offered a restorative treatment option, which is very exciting. All the other traditional treatment options, the pills, the injections, the vacuums, this will not reverse the pathology of the erections. It will not reverse the blood flow issues that he may have. And the shockwave has the potential to do this. And it is first line written into the European guidelines. I do think that the American guidelines will catch up with this probably within the near future. Within the next 5 to 10 years, it will probably be within first line guidelines. We'll see. And in the meantime, I think it's important to see someone who will tell you straight, their opinion of it and not just, charge you for money. So there's my soapbox, my asterisk by that. And again, could do a whole lecture on that topic alone. Okay, so let's dive into each of the standard treatment options real briefly. So oral medications designed to increase blood flow to the penis. This is the little blue pill, the Viagras of the world, the Levitras, the Stendras. I kind of put all these in the same playing field. They'll have similar mechanisms of action. The cost is difficult, although with compounding pharmacies, AUI has our own compounding pharmacy, or GoodRx, we can get pills fairly cheap. Should be a $1 or $2 a pill. You should not be paying more than that. I get guys who come back and say, "Doc, they wanted $600 at Walgreens. I didn't pay that." And I say, "Good. We're going to have you pay $30 for that prescription." So don't break the bank on these. But assuming you don't have any hard contraindications, the most common one being coronary artery disease, someone on nitrates or nitroglycerin. That's one of the black box warnings of interactions. But assuming you don't have any contraindications, I think it's an excellent option to treat ED. Very commonly has side effects that decreases the satisfaction rating. Headaches, frontal sinus congestion. Viagra can have halos or blue light vision changes. Stuffiness. Guys will say, "Doc, it worked great. I had a decent erection, but boy, I couldn't breathe through my nose the whole night." And I say, "Yeah, you're one of the 40%. So we can try different pills, or we can move on thinking about what would the next line be. So vacuum erection devices. This is an external appliance, a cylinder to put the penis in. You're creating a seal at the base of the penis, and at the tip, pictured here in blue, is either a battery-powered button or a manual pump, and you're creating a suction to pull blood into the penis, to put the penis on stretch. And then generally it's used with a constriction band, which I think they're trying to show here in black, a cock ring or a constriction band as a tourniquet to trap the blood in place once the penis is full. And hopefully the patient can maintain some pressurized blood in the penis throughout the act of sex. So I am a big fan of vacuum devices. I usually use them in the prehabilitation or rehabilitation process for my patients. So for example, someone who is anticipating radical prostatectomy, I want to get them started on daily Cialis and using a vacuum even before surgery, so they know how to do it and they're familiar with it. And then post-op, we use it as a rehabilitation maneuver. I use it in the Peyronie's population with penile scarring and stretchability of the penis. The elasticity is an important concept. I find that it has pretty low satisfaction ratings for patients to use as a monotherapy, meaning the only thing that they will try for sex. It's fairly cumbersome. It's not spontaneous. And especially guys who are my bachelors who are having new sexual partners, it doesn't deliver on the spontaneity that we want. So that is a challenge, but we do talk about it. I do think there is a place for the vacuum erection device in these conversations. All right, penile injections. This is very similar to, excuse me, what we give at the time of Doppler ultrasounds in the office. It uses a very small tuberculin needle, like an insulin needle. It's just a 1 cc needle, and it's usually very short, and the pain from the injection itself is nowhere near as scary as just having the process done. Most guys, I'll say, hey, how'd you handle that injection? How you doing this? Oh, it's nothing. I really built myself up for nothing. But the idea here is that we're injecting ingredients mainly based around alprostadil, which is a vasodilator, to try to increase blood flow to the penis, create that smooth muscle relaxation, create that pressurized system where you're getting blood into the penis and clamping off the venous outflow, and hopefully maintaining the erection from anywhere from 10 minutes to something under 4 hours. That's my main concern with these injections. I tell everyone about the risk of priapism. A prolonged erection is generally clocked at 4 hours. And after that, you do risk permanent damage, an ischemic event to the penis, where you have now cut off healthy blood flow, healthy oxygenation to the penis. And could you have long-term issues with erectile dysfunction or otherwise following that? I do warn patients also that about 4 to 5 men that we prescribe injection therapies to, Trimix or Biomix or whatever, Trimix in general, 4 to 5 men will not make it a calendar year. It's similar to the vacuum. It's not spontaneous. It's painful. Guys usually don't like taking a needle to the penis. That's a foreign concept for most men. It has to be refrigerated if we're using Trimix, which is the most commonly prescribed in my practice. So you have to excuse yourself, go to the fridge, dose up, pop the needle in, wait 15 to 20 minutes. And when you put all that together, it's not very spontaneous. Or sometimes guys are traveling and this needs to be kept on ice, so they can't be bringing their lunchbox everywhere for their penile injections. But in patients who it works and they've worked it in with their partner and they have someone who understands what they're doing and why they're doing it, it can certainly help create an erection. Okay. I should have delayed that last question on shockwave to our few slides here. So I do like shockwave therapy. It is a restorative treatment option, which makes it so exciting. We give a protocol of 6 treatments, usually on a Friday afternoon. I tell patients expect to spend 15 to 20 minutes in your visit. And the concept is that we're delivering focused, ultrasound energy to the deep tissues of the penis, almost to induce a very light post-traumatic state. And a couple theories about how this works, but number one, you can be knocking off microplaques within the penile vasculature and opening up those arterioles better. And number two, we're inducing a reparative cascade of growth factors to induce angiogenesis, meaning new blood vessel formation, and try to improve blood flow to the penis. Again, very little side effects, no downtime or pain, and the main risk is really a financial one for this type of treatment. Penile implants is my most common and most favorite surgery. So give me one second. So 2 different types of penile implants. The malleable are basically semi-rigid rods that go into the penis, and you can bend them up for sex and bend them down for urination. And the inflatable 3-piece penile implant. That's what's pictured here. With my practice, I do, by and large, inflatable devices. There's usually only extenuating circumstances for the malleables. With these inflatable devices, it takes me about 45 minutes, just under an hour, to do your whole surgery, skin to skin. And I tell patients, my part will be about an hour, but expect to spend just under half a day in the OR, and you go home the same day. There's no urinary catheter. You're expected to pee in the PACU. And if you could do so, you don't get a catheter. I do leave a drain, 2 or 3 days for a drain, and that's common. We have home health care nurses come out to the house to remove that when indicated. And then we have a couple weeks of downtime, meaning just lay low, you're healing, you're working on icing and trying to prevent any significant bruising or swelling. And then at the 4 to 6 week mark is when we expect the patient to be cleared for sex. So this is something that will really revolutionize the patient's confidence and ability to obtain an erection. The implants themselves are safe. We know that they've been around since the early 70s and have undergone multiple iterations. When I put an implant in a patient, I expect an average lifespan of about 10 years once it's in. And I don't expect it to affect the ejaculation, the urination, or the sensation of the patient. So wherever you are in those categories, after you heal, I expect you to end up in those same parameters. This is really just a way to get the penis rigid and get the penis hard on demand. And it's going to stay that way until you hit the deflate button and the penis goes back down. So again, another topic that I'm very passionate about are those penile implant surgeries. So I'm going to just do a few closing remarks, and I see some more questions come up, but let me just, let me skip to the questions. All right, let's see here. I have a question about BPH, benign prostatic hyperplasia, and a patient had what's called a Urolift implant. It's a procedure to open up the prostate and help the flow of urine, but the patient still has had some symptoms with urination and a weak stream and things like this. So this gets into the BPH urination side of things. I do commonly do Urolifts myself, and oftentimes operate on patients who have had a Urolift or want something additional done. And one of the nicest things about Urolift is that you're not burning any bridges. So very rarely would I consider a repeat Urolift, but what I would likely do is hit the reset button on this patient's workup. He had surgery, he's still having symptoms. I want to do a repeat workup, look at the anatomy again, maybe a urodynamic study, what's the size of that prostate, and consider, is it time to look at resective techniques, a TURP, a HOLEP, aquablation, a resume, things like this, prostate artery embolization, which is not resective, but cutting off the blood flow to the prostate. So there are additional treatment options for bladder outlet obstruction beyond the Urolift that we would consider with the goal of curing their urinary symptoms. So absolutely. Keep the questions coming. I see a few more here. Let me take a moment to read this one. Okay, so we have a question here that revolves around penile injections and scarring. So this is a known complication or side effect from penile injections. So if you prescribe a patient Trimix, penile injections to use, they're going to be taking a needle to the penis and injecting the penis with every sexual encounter. And let's say the patient has, 1 to 2 sexual encounters a week, and you extrapolate that for however long they want to use the therapy, years. Patients using injection therapy for 5+ years. The concept of scar tissue comes from the fact that every needle poke through the penis is a microtrauma, and the penis has to heal. And it's a microtrauma that heals with a very, very small amount of scar tissue. Well, some men are more susceptible to this Peyronie's cascade, where the scar tissue has an inappropriate buildup and it just takes off. And when you have this inappropriate buildup of scar tissue, were these injections the precipitating factor to cause this cascade? And the answer is yes. It's very commonly associated with increased fibrosis and increased scar tissue and penile curvature over time. So I do worry that in someone with a history of Peyronie's disease and someone with a heavy amount of plaque or fibrosis at the beginning, are we going to exacerbate that with penile injections? Are you going to experience loss of length? No one wants to hear that. Are you going to exacerbate their curvature or make their fibrosis work? Worse? Are you going to make future penile implant surgery more difficult? And really, this is a factor of time. It's not like this is going to occur with 1 or 2 needle sticks, and it's not how this process works. But, over time, I have seen those changes. And yes, it does complicate their story. So that's something that we try to talk about up front before embarking on a Trimix regimen. All right. Question on penile implants. What can be done about a penile implant that is not allowing the penis to get erect enough for penetration? So There are a couple different problems that this could be. You could have an issue with the overall rigidity of the implant. Is the implant able to inflate and deflate appropriately? Is it properly positioned? Is it up towards the head of the penis far enough where the distal aspect of the penis and the head of the penis are well supported for that penetration event? The penile implants themselves don't actually go into the mushroom head, the glands of the penis. They stop just shy of it or at the base of the glands. But it should provide a scaffolding for the glands to be almost like a cap to the implant, where you can have that penetrative sex. So, if a patient has had an implant and they're not happy with it, that's when you got to do a physical exam and come in and talk to someone who's very familiar with prosthetic urology and familiar with revision surgeries to see what can be done. There are nuances with Boston Scientific versus Coloplast devices that I talked through. It's important to get a good exam to see the positioning of those tips. Where are the cylinder tips with relation to the tip of the penis? And it's important to see, how inflated can the patient get? So oftentimes I'll sit back and say, all right, go ahead and inflate as much as you can. How rigid can you get it? And then let me take over. And I'm usually more rough than a patient is. And I have a different angle of attack on the pump, and I'm using two hands from a seated position. So if I can get an additional 12 pumps on that device, then maybe we need to talk about inflation techniques and grip strength rather than surgical revision. But the bottom line is, if it's not appropriately positioned, or if the implant itself is failing, now we're thinking about surgical revision, and you need to talk to the patient about what can be done. So good question. And I think I've answered all the questions that have come across thus far. Well, couple take-home messages. Men's health is such a broad category, ranging from testosterone to sexual dysfunction of any variety. Obviously, the erections and the firmness go into that, the curvature, the ejaculation response, all of that goes into the erections, and also the hormone profile of the patient and urination as well. So all of these topics can be rolled into the umbrella of men's health. And there are people out there who can help with each category. Seek help. If you or your partner are struggling with any of these options, come see me, come see an AUI physician. Let's talk about those problems. Let's do the right workup and see how we can get your sex life back. So don't suffer in silence. All right. I think that's it, Alex. I'm going to reach out. Any other questions? If not, it looks like there's a request an appointment box, but that's not a question. I think I'll wrap it up. Thank you, everyone, for being here after hours on a Monday afternoon, Monday evening. I appreciate everyone's questions and participation, and looking forward to meeting some of you soon. Take care.